good morning, everyone. We're going to go ahead and get started. I'd like to welcome you all today to our JBI gLocal Solution Room. And going to try and figure out why this isn't going forward. There we go. So thank you. So briefly, I'm going to introduce you to JBI, the JBI model of evidence-based healthcare, and the origins and purpose of the JBI gLocal Solution Room. So at its core, JBI is concerned with improving health outcomes in communities globally by both supporting the use of the best available evidence to inform decisions made at the point of care. And in fact, this work begins and ends with the needs of those who are working in and using healthcare services. JBI is seeking to respond to their questions and provide high quality, reliable information that is both pragmatic and useful where it counts. So who is JBI? Who are we? It's a global organization that promotes and supports evidence-based decisions, improving health and health service delivery. It offers a unique range of solutions to access, appraise, and apply the best available evidence. And to do this, JBI works with universities and hospitals from really across the globe through the JBI collaboration. In doing so, JBI ensures that the research evidence it seeks to synthesize, transfer, and implement is culturally inclusive and relevant across the diversity of healthcare internationally. So for those of you who are maybe unfamiliar with JBI, our vision is to provide better evidence to achieve better outcomes and a brighter future. Our mission is to promote and support the use of evidence at the point of care globally. But of course, JBI can't do that alone from Adelaide, Australia. So international collaboration really truly is critical, not only to us, but to the broader evidence-based healthcare endeavor. So JBI's approach to evidence-based healthcare is unique. JBI considers evidence-based healthcare as decision-making that considers the feasibility, appropriateness, meaningfulness, and effectiveness, or FAME, of healthcare practices, the best available evidence, the context in which it's delivered, the individual patient and professional judgment and expertise of the healthcare professional informs this process. JBI regards evidence-based healthcare as a cyclical process. JBI, global healthcare needs as identified by healthcare professionals or patients or consumers are addressed through the generation of research evidence that is effective, but also feasible, appropriate, and meaningful to specific populations, cultures, as well as settings. So in order to provide those who work in health systems globally with world-class information and resources, JBI considers international evidence related to the feasibility, appropriateness, meaningfulness, and effectiveness of healthcare interventions. So that's the evidence generation. Includes these different types of evidence in formal assessment called a systematic review or evidence synthesis, globally disseminates information in appropriate, relevant formats to inform health systems, health professionals, and consumers, known as evidence transfer, has designed programs to enable the effective implementation of evidence and evaluation of its impact on healthcare practice, which is evidence implementation. In this unique approach that is encompassed in the JBI model, it is this unique approach that is encompassed in the JBI model of evidence-based healthcare. So despite evidence-based healthcare in organizations like JBI having been in existence for more than 30 years, we know that a research to practice gap still exists across all fields of healthcare. A commonly quoted estimate is that it takes an average of 17 years for 14% of published evidence to be widely incorporated into clinical practice This lag in uptake is due to numerous gaps in the movement of research from one stage to another, including ineffective dissemination. This is where JBI's evidence implementation framework is firmly situated. Evidence-based clinical audit and feedback is a valuable approach to implementing evidence into practice. Recognizing and understanding the role of professional culture, organizational support, and leadership in this process is really pivotal to its successful utilization. A JBI evidence implementation project is a clinically oriented, team-based initiative towards implementing the best available evidence into an organization's systems and processes of everyday care. These evidence implementation projects are quality improvement initiatives utilizing a very similar approach to the plan, do, study, act cycle, encompassing clinical leadership and evidence-based practice change. The JBI implementation approach is firmly grounded in the audit, feedback, and re-audit process, and a structured approach to the identification and management of the barriers to change. This approach is successful in the JBI evidence implementation program, where more than 800 healthcare professionals have successfully implemented and changed practice following this framework in both small, single unit or single site, and large multi-site studies. The widespread impact of the work of JBI worldwide is attributable to the local and global partnerships that ensure that activities are context-driven by individuals and groups who understand their specific healthcare environments. Through its international evidence network, JBI is well-positioned to be a leader in producing, disseminating, and providing for the use of the best available research evidence to inform clinical decision-making to improve healthcare outcomes globally. The JBI collaboration is the engine that drives JBI worldwide effort to promote and support the use of the best available evidence to inform decisions made at the point of care. JBI collaborates with more than 90 entities in all regions of the world. Collectively, these collaborating entities are known as JBI collaboration. The JBIC is the largest global collaboration to integrate evidence-based healthcare within a theory-informed model, bringing together academic entities with hospitals and health systems. Collaborating entities are self-governing and are initiated and coordinated through JBI. We're driven by a united desire to contribute to the improvements in quality and outcomes of healthcare globally through the delivery of high-quality programs of evidence synthesis, transfer, and implementation. The functions of the JBIC are directed toward the knowledge needs of local clinicians and consumers, with each collaborating entity, like ours here at Lurie Children's, leading evidence-based initiatives in their region, country, state, or specialty. Events like the JBI gLocal Solution Room are just one way that JBI entities are promoting and supporting the use of best available evidence to inform decisions made every day at point of care. Before we begin with today's sessions, it'll be helpful to understand the origins of the JBI gLocal Solution Room. What is gelocalization? Gelocalization was popularized by the sociologist Roland P. Robertson, who traced its roots from a Japanese business term, dochikuka, which emphasized a global outlook adapted to local conditions. Glocalization stresses the idea of contemporary globalization influencing the local level of society and the localization of globality. So what does glocalization have to do with evidence-based healthcare? The JBI model of evidence-based healthcare recognizes first and foremost the critical relationship between research and practice. The yellow wedge at the top of the model speaks to both globality and locality of evidence-based healthcare. In simple terms, Evidence-based healthcare begins and ends with the needs of the health professionals, health services, and health service users. If researchers and synthesists are not engaged with those working in practice, are not responding to your knowledge needs, then we will never achieve sustainable improvements impacting where it matters most. That is why events like the gLocal Solution Room are really so important. Answering the right questions, answering questions that matter as they relate to not only the effectiveness of interventions, but the feasibility, appropriateness, and meaningfulness of those implementation efforts is vital to the success of implementation. Working in collaboration with you to determine what those questions are, then supporting you to implement the answers is the only way we can achieve our mission and vision. Therefore, thinking about the application of evidence context is really key. JBI is cognizant that it is our responsibility not only to provide healthcare professionals with the best evidence, but support them in its use. Again, it's not possible without connecting in person, without acknowledging and accepting that different cultures and clinical environments present different challenges. And we hope that this event, or rather the series of events that are happening for the gLocals around the world, contributes to overcoming some barriers, to helping us understand the challenges that you're facing and provide an opportunity to generate solutions together in partnership. The idea of the solution room came from a powerful conference session concept designed to engage and connect attendees, but also provide peer-supported advice on pressing issues. While the JBI event doesn't strictly follow the format of the original idea, the concept of being solution-focused and pragmatic was really attractive to JBI. Pairing that with real-life challenges related to implementation seemed an obvious choice and a perfect opportunity for JBI and JBI collaboration to engage with those we seek to support, going back to our mission, vision, and model. There's learning to be achieved on both sides of the podium. It's an opportunity to share experiences and co-create partnerships for the purpose of achieving better health outcomes by applying global knowledge to local challenges. We hope you enjoy the sessions today in finding solutions to your EBP challenges. So our hope is that you will connect with JBI as well as with Lurie Children's as you travel your path for evidence implementation. So again, welcome all in the room and all online. I know we have, or I hope we have some registrants I know from across the pond. So good afternoon and good evening to you. We will be starting our whole session from policy to practice in a JBI gLocal Solution Room, making evidence-based guidelines usable at the point of care. So this is our schedule, which you all should have received. So we are going to go ahead and get started. And I'm going to do an introduction of the first speakers for the first session titled Clinical Care Guidelines at Lurie Children's, a Program Overview. So our presenters are Allie Shaw, who's a healthcare improvement consultant and Lean Six Sigma Black Belt with more than a decade of experience advancing quality and operational excellence in pediatric healthcare. She specializes in building quality governance structures and leading complex system-level initiatives, strengthening accountability and driving sustainable improvement. Becca Stevens, pardon me, is a pediatric hospital medicine attending and assistant professor of pediatrics at Northwestern Feinberg School of Medicine. She has a master's degree in healthcare quality and patient safety and currently serves as the medical director for the Center for Quality and Safety at Ann and Robert H. Lurie Children's Hospital of Chicago. Jackie Corboy is attending physician in emergency medicine and in emergency medicine, the director for quality. She's also core faculty for the Center for Quality and Safety. Manisha Patel is a senior clinical informatics analyst in clinical informatics, and Jade Clark is a manager for improvement consulting in the Center for Quality and Safety. So I'd like to call them to the podium to begin their presentation.
All right, great. I will kick us off. As Lauren mentioned, I'm Becca. I'm our medical director for CQS, and I get the distinct pleasure of kind of introducing the beginning parts of our clinical care guideline program here at Lurie. So what we hope to talk about today is really the importance between the collaboration between our quality department, clinicians, and our informatics team with our order set and our patient family experience programs, like bringing them all together and the importance of tying everything together as opposed to working disparately. We'll also spend some time talking about how we use structured methodology that's evidence-based to really develop all of our clinical care guidelines. So Allie will talk about this a little bit more later, but we use a framework called DMAIC, which is a well-known and well-published quality improvement framework that allows us to have some standardization amongst all of the guidelines that we have. We'll also talk a little bit about how we evaluate the literature and the best evidence available using GRADE. We'll talk about something that I personally think is really exciting and pretty new for our program and new for guideline programs in general, which is our approach to how we embed equity throughout the development of quality initiatives and specifically our clinical care guidelines. And then last, we'll talk about how we've, over the last couple of years, established a pretty robust process for governance, measurement, and sustainability strategies that allow us to ensure that our guidelines are up to date, they're still relevant to the clinicians using them, we have good adherence to them, and that these guidelines aren't just guidelines, but they're really having an impact in the places where we provide care. So stepping back a little bit, where does our clinical care guidelines, or what you'll hear us maybe call CCG, just because clinical care guideline takes a long time to say, our CCG program within Lurie Children's. So Lurie Children's has a Center for Quality and Safety that really encompasses all of the domains of quality defined by the IOM, or Institute of Medicine. So we have safety science, we have clinical effectiveness, we do improvement consulting where we help teams throughout the institution perform their quality improvement projects and set up their own governance. We teach a lot of quality improvement methodology to our organization, and then we also encompass our patient family experience. What we'll be talking about today with our CCG program really fits very nicely within our clinical effectiveness program. Again, the goal being taking the best evidence and moving it into practice as quickly as possible as we can in our institution. And so with that, starting kind of broadly with the purpose, again, the purpose is to integrate evidence into practice. If there happens to be something that we see as a quality or safety issue that would benefit from a guideline and there isn't robust evidence in the literature, some of our clinical care guidelines have components of them that are more consensus-based than evidence-based, but in general, if there is evidence available, we use that as the gold standard. The goals are to reduce unwarranted variation in care processes with the goal of improving health outcomes. This guides our improvement efforts. And then I just wanted to call out really early, these are a little bit different than protocols. With a protocol, you have a list of things to do and you follow them 100% of the time. That is not the goal of our clinical care guideline program. It's really to provide a framework to reduce that unwarranted variation, but allow for variation when it's clinically appropriate. So we would never expect 100% compliance with any of our clinical care guideline programs. We really want the experts at the bedside to know what to do most of the time, but then to trust their gut when they say, something seems a little bit off with this and I don't want to follow this pathway completely. I'm going to do something different because it's warranted based on what the patient is doing or the family is saying. So that's a distinct feature, that it's a little bit different than a true protocol. And they're really not meant to replace judgment. Our clinical care guidelines have three kind of large components to them. One is the algorithm itself, which kind of walks through who's included in it, what you will do kind of step by step. We'll show you some examples throughout the course of this presentation. We also embed clinical decision support tools, which we'll talk about in a lot more detail over the next 30 minutes or so, with the goal of being able to have the guidelines sit where clinicians are doing work, hardwiring them in our EHR, which for us at Lurie is Epic, just to make it easier to follow the guideline where you're not looking in a couple different places at the same time. And then we also really wanted to make sure our patients and families were incorporated and that they're getting information that helps them know what we're doing to implement best practice and then also keep them informed. A little information on our program history. We started in 2014. I believe bronchiolitis was our first clinical care guideline program here at Lurie Children's, and have really grown pretty substantially over the last decade. We went from 3 CCGs in 2014 to about 120 to date. We currently have 8 new CCGs in progress, and there are 15 that are going major updates. At the current moment, it takes us a little bit over a year from when we decide we're going to do a clinical care guideline here at Lurie to have that fully baked in our processes here at Lurie, between developing it, building all the tools to support its implementation, and then educating our teams on it. We initially facilitated all of these through our Center for Quality and Safety, but as our improvement capacity across the organization and improvement expertise across the organization has increased, some of these CCGs are now led locally by leaders in the organization that still come through us for some overall governance. Again, we're built on Lean Six Sigma DMAIC, and implementation is a really core component. Like, we really don't want to create beautiful documents that tell you what to do, but then not actually have them make it to the bedside. So we focus a lot on implementation within our program. And with that, I'm going to pass it over to Manisha Patel, who is online, to talk a little bit about our order set program.
Wonderful. Hi, everybody. Thanks, Becca. So yeah, I wanted to talk to you guys a little bit about another program that's sort of essential for operationalizing our clinical care guidelines within EPIC. Well, I should confirm that you guys can hear me, since I'm the only one online.
Yes, I can hear you.
Okay, thank you. Yeah, so I wanted to talk to you guys about our order set program, and it has a few key functions, but for the purposes of today's presentation, I really wanted to focus on the operationalizing of our clinical care guidelines within EPIC. And what that really entails is translating our clinical content that we're putting together for our algorithms and hardwiring all of that content into our EHR system, which is EPIC. And some of the other key functions also include, ensuring consistency through our build standards and guiding principles. And what this really does is standardizes our look and feel of all of our order sets within EPIC, so that it reduces the cognitive burden on our ordering providers, and also improves our efficiency. And like I mentioned, for the purposes of today's presentation, we'll focus mostly on how we embed guidance right at the point of order entry, which seems to really align with the philosophies behind JBI, and then also how we use CDS, or clinical decision support, to influence decisions in real time. So today we'll be focusing on those two things of guideline translation and then also embedding decision support. So here we wanted to show a quick screenshot of how we have our algorithms accessible right at the point of order entry, or sorry, right within EPIC. And so this menu shows, this screenshot shows our web links menu, and it shows that we have all of our CCGs accessible within EPIC. This sort of serves as our library of all of our clinical care guidelines and algorithms within EPIC. And then on a future slide, I think we have a couple screenshots of how we have the links embedded within the order sets as well, for our ordering providers to be able to access them right at the point of order entry as well. And so here we have our algorithm sort of just organized. This menu has grown from about 5 algorithms early on at the beginning of our program, and now we have about 120, as Becca mentioned, that are live, and they're all accessible within this web links menu. And this menu is accessible for all of our inpatient providers, and then also our ambulatory providers. And then I think I'm going to hand it off to Allie to talk through our DMAIC process.
Thanks, Manisha. So as Becca and Manisha mentioned, we use Lean Six Sigma to develop our guidelines here at our organization. And we wanted to give you a little bit more detail on what that looks like. If you're familiar with DMAIC, we use slightly different language to describe each of the phases here. It was just a better cultural fit for our organization when we developed the Lurie improvement framework, but it's really the same process if you're familiar with DMAIC. So we start out with project initiation, which is where you charter the project and figure out what you want to accomplish with the guideline, including scope and any more specific metrics outside of your outcome measure. From there, we work on building our stakeholder team, a really inclusive stakeholder team. If there is a stakeholder group that cares for that patient population, we invite that group to have representation on our development group, so it can lead to large groups of people, which I think is a really important change management component of how we do our work here, because we're bringing everybody along from the very beginning of the journey. From there, we move into the current state analysis phase. There's a lot of different important things that happen at this phase in the process. We're collecting our baseline data. We get into a lot of granularity around building that patient cohort, often down to the diagnosis code or the CPT code level. We also concurrently work on our lit review, which I'll share in a couple of slides, what that process looks like for us. We also benchmark with other organizations, and then we always do a very thorough barriers assessment and workflow analysis using typical DMAIC tools like process mapping or root cause analysis. That takes a large chunk of that 13-month that Becca mentioned earlier, and that's really all the inputs that we bring into the future state design piece of the process, which is where we're developing our algorithms. Oftentimes, if there are existing algorithms at other organizations, we'll start with a benchmark version of the algorithm for people to react to, and then kind of take all of those inputs from current state analysis to make it fit our organization and the most current literature, as well as our baseline data. And from there, that is when we start working with Manisha's team to build out those CDS tools. We, as Becca mentioned, build patient and family materials, and then we also make sure that the guideline aligns with any existing policies, protocols, or procedures to make sure that it's really functioning seamlessly across the organization. From there, we move into testing and implementation. We do ask that our guidelines come to our steering committee for review and approval prior to implementation. That's the group that you hear presenting today. We review and approve all of them as of January 2024, I think, or maybe the summer of 2024 is when we launched that. But from there, our teams educate and train all of the frontline staff on the guideline and do kind of a big bang implementation most of the time. From there, we're doing iterative testing, PDSA cycles, to tweak the guideline to make sure that it's functioning as intended in our environments. I think a really important part of that is making sure we have our data and are looking at it over time in control charts or run charts to make sure that we have a good sense of how the data, both adherence data and outcome data, is changing in relation to our PDSA cycles. That's also a really important part of sustaining the work over time. These are living, breathing documents, and the work really never ends in that regard. We also have a venue for our CCG teams to bring their post-implementation data. That's our governance structure meeting where they are sharing that information more broadly across the organization for how things are working. Okay, I will move on to a little bit more detail now on our lit review process. I think this is probably going to look familiar to many of you. We start by defining our clinical questions. Again, this happens during the current state analysis phase of our projects. Oftentimes people come to us because they know that there is evidence that we need to be integrating into practice, but we do, for many of our guidelines, go through this formal structure. We currently use the PICO question construct to form our clinical questions, although we are considering switching to the PPCO framework right now with one of our internal improvement working groups. From there, we move into the literature search. We're really lucky to have Andrea, our hospital librarian here to help us with many of our large searches. She designs that search strategy based off of our PICO questions. From there, we move into abstract screening. I'd say the gold standard for us is to have 2 independent reviewers for each of the abstracts. I will say that that depends on the capacity of the clinical team. We do rely really heavily on our clinicians for this part of the process, as we do not have a team of medical librarians as other institutions, some other institutions do have, but that is what we're striving for. From there, we move into full text review. We do have a standard Excel template that our team uses to extract the data and organize it and set us up for success in the assessment and grading phase. We, as Becca mentioned, use the grade framework to grade our literature, and a kind of core component is that is assessing certainty by defined outcomes. So we're not doing that on a study level, but we're looking at kind of the outcome that we are interested in for that portion of the literature review and assigning a rating that way. All of that kind of summarizes into a recommendation table that we include at the end of our guidelines. I'll show you in just a second what that looks like. And then a big focus for our consultants and our clinical leads is to make sure that it's not just living in that table at the end of the document, but it's actually integrated into what is in the process map and the algorithm in the guideline, so that everything agrees with each other. Like I said, we have some improvements in process here. We're thinking about switching to that PPCO construct, as well as a number of other things for our consultants internally. We are always trying to improve our processes as well. Okay, we thought it would be helpful to show you one of our algorithms. So this is a pretty standard example of what our algorithms look like. This is our musculoskeletal infection CCG. It focuses on acute osteomyelitis and septic arthritis. This is the ED of the emergency department algorithm. We also have a page for inpatient procedural guidance and antibiotic tables. You can see there's a lot of information in the sidebars over here. I will not get into the minute details there, but something else that we started doing recently is adding a standardized appendix to the end of all of our algorithms. This includes the problem statement, the inclusion and exclusion criteria, as well as all the metrics that we monitor. It also includes version history and all of the contributors to the guideline. We found that over time, some of this information was getting lost when we weren't documenting it really explicitly in the algorithm itself. And it was just living on the L drive, and it made it a little bit more challenging to sustain over time. So this has been really helpful for us. And then, of course, we have our recommendation table. This guideline had a very, very thorough literature review. They started with about 2,000 articles to screen. There's 5 different lit review subgroups focused on antibiotics, labs, imaging, surgical guidance, and there was a kind of an other category. So I don't know how well you can see that on the big screen here, but we have a column that kind of summarizes, provides a summary and a recommendation grade, does recommend that you separate those two pieces out. However, for practical reasons, to make sure this was really usable for our frontline clinicians, we do combine those two fields. We also have strength of recommendation and then the quality of evidence, and we do all of that according to how grade recommends you complete that part of the process. Okay, so we're going to go into a little bit more detailed case study now using our tonsillectomy and adenotonsillectomy CCG or TNA CCG, and show you sort of how Manisha and her team translated that into some of these CDS tools. So this is a pretty representative example of what our surgical guidelines look like. They're often organized by phase of care, so pre-op through post-op, as well as what happens for the patient at home. This guideline, the main outcome that they were trying to achieve was a reduction in opioid use in this patient population. At the time that they were developing this, there was a good amount of literature coming out about the harms of opioid use in this patient population, as well as a growing body of evidence that ibuprofen could be used successfully when alternating, in particular with acetaminophen. There was also not a great standardization across the surgical team at that time. I think there was 12 different surgeons and 6 different guidelines that they were following. So that was kind of where they were starting with this. And then I'm going to pass it back over to Manisha to walk through some of the CDS tools. Take it away, Manisha.
Thanks, Allie. So on the CDS side of things, we're on the right side of the screen, we're looking at the order set, so a screenshot of the order set that's associated with the tonsillectomy and adenotonsillectomy CCG. That sort of is a collection of all of the orders that we need for an order set extracted from the left side of the screen where we're looking at the algorithm. And so if we go into the next slide, we go into a little bit of a framework before we jump into a little bit more of the case study and examples. But here we have the steps for going from an algorithm to an order set. And really, it is a stepwise approach. And I think that there's a lot that goes into sort of what Ali alluded to. There's a lot that goes into the development of the algorithm, and really the finalization of that algorithm is what sort of kicks off the design and development of the order set. And so that second step there is where we're sort of extracting all of the orderable items from an algorithm, where sometimes they might be a little bit more nuanced and sometimes they're a little bit more obvious. So the more obvious ones might be things like, lab orders, medication orders that you have listed in the algorithm that you definitely know you need to have as an order in an order set. But there might be other things that are a little bit more nuanced, like nursing communication orders or nursing assessment orders, things that instruction that you want to give the ordering providers at the point of order entry that you might have embedded in the algorithm, and then that you might find beneficial to have at the point of order entry as well. So then we jump into the order set design per our guiding principles to meet our guiding principles as well as our build standards. And so we take that full list of extracted orderable items that we had from that second step. We make that collection of orders into a nice template. And then we embed any guidance. So embedding guidance right at the point of order entry, we'll have a couple screenshots on the next slide of that, but really just embedding any sort of evidence-based guidance for our ordering providers right at the point of order entry is really beneficial. It's, because it's right there when they're placing their orders. Then we also take it a step further to apply some CDS logic. And so if there is anything that the ordering providers, that we can make it easier for the ordering providers to do the right thing. So what that really means is making sections of the order set appear or disappear based on certain logic. So we'll do that. And then we go into the standard steps of build, test, and validate for all of our tools. So order sets really do serve as our primary mechanism for operationalizing our CCGs within Epic. On the next slide, we have a screenshot here of our post-op TNA order set, and really wanted to highlight here some of the CDS logic that I referred to. So this screenshot is showing a patient that is 3 years old, and they have the pain regimen defaulted for them of acetaminophen and ibuprofen. Then they also have the option of switching off of the acetaminophen and ibuprofen to select acetaminophen only if ibuprofen is contraindicated. So a pretty standard approach here, where if the patient is less than 5 years old, they have this pain regimen, and these are the only 2 pain regimens that they can choose from. If you go to the next slide, very similarly, now we have the patient that is 6 years old, and you see a couple more options in the pain regimen choices that are defaulted. So this is the same exact order set and same exact section of the order set, but on the back end of the what we've embedded into the logic, if the patient is greater than 5 years old, which is the age that our organization agreed upon and reached consensus on for when we wanted to allow for opioids to be given, or have the option of opioids, that now, since the patient is 6 years old, we have additional options of opioids to switch away from the acetaminophen and ibuprofen. But again, the acetaminophen and ibuprofen is the defaulted option. And then the embedded guidance there that I sort of mentioned also here, where like if we do have the option of selecting the opioid, but we also wanted to provide the guidance for the ordering providers to let them know when they should refrain from ordering the opioids. So while we give them the option, we want to let them know what the evidence is saying in terms of when to avoid giving the opioids. On the next slide there, I just wanted to show a quick screenshot here also of our discharge instructions. So sort of made it really convenient for our ordering providers to, when they're switching the pain regimen, the discharge instructions that populate also are switching. So all of that sort of happens within one click. So when we're on the acetaminophen and ibuprofen pain regimen, it had the discharge instructions that were relevant to those. And now we're on the acetaminophen, ibuprofen, and oxycodone, it has the updated discharge instructions relevant to that pain regimen. So making it really easy to do the right thing and also provide the appropriate instructions to our ordering providers. And then I think I'm going to hand it off to Ali to talk a little bit more about those discharge instructions and patient and family education materials. If you go to the next slide.
Yeah, really briefly, wanted to show another example of patient and family education materials from one of our guidelines. We are really lucky here to have a patient and family education consultant who maintains a very robust library of patient and family education that often in conjunction with CCGs. We also link it directly within our CCGs so that the team can click straight to them. However, if there are more comprehensive educational needs, we have actually co-designed materials with families in the past. This example on the screen is from our laryngotracheal reconstruction CCG, which is a pretty intense surgery and recovery. So we worked with 4 LTR families to design more than 40-page booklet, and that covers kind of the full journey from surgery through discharge. I'm going to pass it over to Jade now to talk through how we incorporate equity into this process.
All right. We'll try and make this brief. All right. Touching on our race, ethnicity, and ancestry framework, this is one of the newer components to our CCG program. And this was born out of a bow tie analysis that focused on bias in safety. And we wanted to be able to identify where bias could potentially contribute to harm. We began this work in the winter of 2024, and we went into implementation this past spring. It took us some time to develop the practical guidelines that we knew would help our teams to put this work into action, and we want to be very purposeful about that and make sure that we were developing tools that would make that happen. Oh, geez, sorry. Oh, there it is. Wonderful. Yeah, like that. So sorry. Wonderful. All right. So once we started working on that framework, the next was to identify steps where teams could start to apply it. We knew that we had really had 3 opportunities in this work. And those 3 were identifying race, ethnicity, and ancestry language appropriately. The second thing we wanted to focus on was embedding equity-focused statements directly into our algorithms. And finally, acknowledging limitations of clinical tools that were in practice, looking at things like our pulse oximetry, which really had impacts on certain patient populations, and we wanted to make sure that we were incorporating appropriate language around those tools into our algorithms. But we didn't want our language to live in just a few sections of our CCGs. We wanted to make sure that equity was integrated throughout the entire development process. So to do this, we built guidance documents that ensured that equity was incorporated into every phase of CCG development. You'll see that this slide looks quite familiar. Ali had talked through the different phases of CCG development, and you'll see here some examples of where we were able to incorporate some of the tools that we were developing and encourage our teams to think about equity in each of these various phases. We wanted to make it practical for our teams, and so we also helped them by creating standardized documents to help with these considerations. Here you will see our equity template, as well as an example of some language that we created to assist our teams. We wanted our teams to include neutral evidence-based statements about disparities, so we helped with some of that language. And we wanted to ensure consistency and avoid assumptions. We also connected this work to our internal bias reporting tool, allowing our teams to capture and further investigate when there were potential bias in the work that was occurring and care of these patients. And so allowing them to directly have links to where they could report that information and have internal teams to evaluate. So shifting gears a little bit, embedding equity is one part of building strong clinical care guidelines, but sustaining them also requires a strong governance structure. So this brings us to the structure that we have developed. This was developed, we haven't had it in place for a terribly long time, but as our program started to grow, we recognized that we needed some governance around it. And so we developed this 2-tier structure that you'll see on the right side there. We have our steering committee, as well as our governance committee, and each of them really have different focus areas that you'll see listed here. And our governance structure really functions throughout the CCG cycle as well. So they start by prompting a review of the literature 5 years after a CCG has been developed to ensure that, or a little bit before that, to ensure that we are looking at these at a set period of time and updating them as appropriate. We also set expectations with our clinical leaders, review and approve our CCGs prior to implementation. And then we create a venue to look at the data that's being collected with our CCGs and ensure that they are being utilized throughout the clinical environment, and also look for opportunities for improvement of these CCGs. And with that, I'm going to pass it over to Jackie, who's going to talk a little bit about our measurement and sustainability within this program.
Thank you so much, Jade. Can everybody hear me? Just making sure my connection's okay. All right, thank you. So as was mentioned a lot throughout this talk, we don't know how well these guidelines are affecting our patients without measurement. So I'd like to talk a little bit about what we use for measurement, why we measure, and the principle of sustainability with implementation efforts. So on the next slide, just a little bit of background about quality measures and measurement overview. Many people are much more familiar with measurement in research, but I'd like to really just give you an overview of the difference between measurement for research purposes and measurement for improvement purposes. So the National Health Services Institute for Innovation and Improvement defines 3 main circumstances or reasons why we would measure. And for the purpose of today, I'm going to focus mostly on the difference between research and improvement. So clinical care guidelines are measured with improvement in mind. There is no hypothesis that we are trying to prove or disprove, but research and improvement science really are hand in hand. And so we use the evidence that is generated through hypothesis-driven research in our implementation and in our improvement work. But measurement for improvement, as opposed to measuring a specific outcome or whether or not we're proving or disproving a hypothesis, is really to see how our changes are improving care over time. And it's really to look at the outcomes of those changes that we're implementing as it pertains to patient care and improving patient outcomes. So in the next few slides, we have some examples. So this, what you're looking at right now, is something called a statistical process control chart. And this is a small measurement section of one of our clinical care guidelines pertaining to patients with fever in the oncology setting. So I'm sure you can see there are many different points on here and lines that are, both going up and going down. So what this represents is changes that we have made through the clinical care guideline and order set process, and how that is impacting specific measures that we set for this. It's an outcome measure that is decreasing the time during which results are available to providers regarding a neutrophil count or a critical neutrophil count in febrile oncology patients. So on the left side of the graph, you could see that when we started out this process, the time that it took between sending a blood sample down and receiving a result of a critical neutrophil value took a long time. On the side, I know that this is pretty small, but we were upwards of 30 minutes between the time that the clinician had an opportunity to initiate care for that patient population and when they were actually able to initiate that care based on the result. There were several interventions that occurred. First and foremost, the creation of a clinical care guideline and an order set for this population, and some work that occurred in a multidisciplinary approach between lab, nursing, phlebotomy, our Epic reporting system, et cetera, to get those results to the clinical care team in a much quicker fashion so that we could make informed decisions faster. So you could see that over time as these lines, we call them shifts, move up and down the graph. The direction that we want this to go is smaller amounts of time between sending the test and receiving the result. And through many stages of implementation, we have decreased that time to receive the result from closer to 30 minutes to now we're just a little bit under 15 minutes. So, how that affects the patient is that they are able to receive necessary care, which would be antibiotics if they have a critically low neutrophil count, in a much more timely fashion, which will hopefully improve outcomes such as morbidity and mortality. The type of visual graph that you're looking at right now is generated through a platform called Power BI. And our long-term goal is to have all of our data for clinical care guidelines available to clinicians in this type of visual format, which really conveys a lot of information to the care teams and also to leadership teams about our ability to enact change in these populations through things like clinical care guidelines and order sets that drive appropriate care in the direction that we're going based on research driven evidence. Right now, about 25% of our clinical care guidelines are available. Yeah.
We're being told in the room that we're at time. I'm so sorry to cut you off. We're just gonna pop forward really quickly on the slide.
So sorry.
So sorry
yeah.
about that.
So in summary, you just saw sort of the visual cues that we get to know that our changes are making improvements. But we just wanted to let you, show you how clinical care guidelines can really translate research-driven evidence into practical workflow integrated guidance that support real-time clinical decisions at the point of care. We use the paired structures that we talked about, such as DMAIC and GRADE, to ensure that there is rigorous evidence in the review process and that implementations can be adapted with local context in mind. Order sets and other clinical decision supports that allow these algorithms to direct real-time care are very important. And they help clinicians make choices that support this evidence-driven care. I think one of the biggest things that we learned was that development of a governance structure really allowed for standardization of practice. It allowed for ownership and scheduling routine updates that ensure that the delivery of care is high quality and evidence-based and as current as possible. And we continue to strive for continuous data monitoring so that we could support learning, measure adherence, and improve outcomes. And then finally, by integrating the process to promote equity considerations through this entire CCG development process, we hope to strengthen guideline relevance and impact across all patient populations. So at this point, thank you so much for your time and attention, and we welcome any questions.
Thanks to everyone. This was actually really quite excellent.
Thank you.
So I think we have time for one question. Anybody online, you can put your question in the chat. And for those who are participating online, because we don't have a lot of time for questions, if you want to put your question in the chat, we can ask that the speakers respond to it at some point today during the session. Anyone in the room? Okay, I have a question. What has been your biggest challenge?
I think, here, I'll get on the microphone. I think our biggest challenge has been getting data on 120 clinical care guideline programs that truly matches the patient population that we're trying to serve in a way that we have it readily available at all times, given like the limitations of the electronic health record, and really identifying patient cohorts properly for this. Because there are obvious exclusions that we wouldn't want to be including just everything that you can capture with a diagnosis code from Epic. So there's a lot of code on code on code to get the patient populations correct. And that sometimes lags quite a bit behind.
Yeah, and I think that's a good example of why it's a clinical care guideline and not a protocol,
Correct.
because it has to be applied to the right patients in the right setting with the right diagnosis.
Yep.
So I'd like to thank Allie, Becca, Jade, Manisha, and Jackie for contributing to this incredible session, teaching us all about how we do CCGs here at Lurie Children's, and acknowledging Andrea Fawcett, who's not here speaking, but also a member of our core JBI at Precise here at Lurie Children's. So thank you all. We now have time for a 5-minute break, and then we will resume promptly at 9:45 local time.
Did you want to come back?
Yeah, I don't either. Yeah, you got added over time, but I come to you. Truly, I'm assuming in many ways, like is it clinicians identifying patterns? Situation. CQ. It's like. Oh, gross. What do you want? 3. Patients got accessible. People are coming. So I was like, Zoe's holding my phone right now.
Yeah.
I like rapid
people doing it.
applications and around the applications.
Okay.
So most of our. And then our leadership team show you how we got there to this meeting, but I should review those. I don't feel that way. And what we have right now. I love it when you so careful.
This, yeah.
Like you were saying.
Thanks, team.
Like, great.
Sorry to have to see you guys.
Well, no, it's fine. We also have Jackie for both night. The ED is Jackie is like the very proposed thing on each line, and then you get.
Yeah.
Yeah.
That's great.
I think that's good.
You don't have to.
Or
Take your 30 minutes.
Yeah. Yeah.
We're gonna run, but I knew it. No, that's great.
So many meetings.
Like,
I know. I know. I'm tired of not getting jig work.
Sure.
Like, I really, calendar.
Joe, I so I have time to do work or just
Think,
respond to emails.
Right.
What is?
I don't thinking, we don't think about building it.
You need it, otherwise you like. Put out fires, but you don't ever do anything else.
Right,
And then.
right. And what we do requires thinking.
But that was
Yep.
one of. Well, it was good today.
Thanks for coming. So you've been good?
Right. You know, in education. When I was looking, what I see most of the outcomes. And these will be able to join.
Yeah.
That's what you'll be. Yeah, I feel like about just have like one interaction that we did from him and seizure.
This. Yeah.
Yes, yeah, but we'll
Well,
walk
we
through
have
that.
to-
There's a, you know, we.
Yeah, but aren't
as
they-
educators, so that we see those, yeah, pieces.
Yeah.
Yeah, okay, I'm so curious. So, yeah. In particular.
Crazy, my last shift was, like,
You guys will come back to just shut anything. Yeah.
Change. Will be different.
Yeah.
Oh my gosh, yeah.
I don't know. It's like the basketball training. I remember students. Specific triggers. Two dark horses.
No.
She's like.
So.
Right.
But
There's a lot to cover.
be here. That's so unfortunate. I did almost, but no one texted, so you may or may not receive an email.
Everything.
But
Yes, yes,
Crazy,
yeah.
and it's supposed to be.
Hi, everyone, we're back. So our next speaker is Dr. Shira Toyster. She joined the Division of Hospital-Based Medicine in 2022 and has completed her, after she completed her residency at Lurie Children's Hospital. She co-leads multiple quality improvement projects, including the asthma CCG, and is also involved in medical education and division leadership. So Shira is going to talk to us today about our asthma management CCG. So welcome, Shira.
Thank you, Lauren. So as she mentioned, I'm going to talk about the development of our asthma CCG and incorporating the best evidence into our implementation of it. So just to go through an overview of the talk, so I will go through our approach to updating the asthma CCG, our literature review process, the changes we ended up making to the CCG, and the results of the changes on our length of stay and other QI metrics that we use. And then I'll end with what is next in our asthma CCG. So when we started the overhaul of our asthma CCG in 2024, came up with a fishbone about what are the things we want to tackle, what are the problems we're having with our current asthma CCG that's impacting our length of stay and our other quality metrics. So for length of stay, there was a lot of confusion around prescribing controllers for discharge. So we weren't sure which controllers we would order, what would be covered by insurance, when the pulmonology team would need to be involved in order to recommend the controller. We also were having trouble with some of our discharge orders. There was lack of clarity regarding the action plans, how many asthma albuterol puffs to give for each patient with asthma. And then there were some discrepancies about whether or not we would give 4 or 6 puffs, which I'll get into a little later, especially in the yellow zone. So that was impacting our length of stay. We also had some concerns about LCAS, our Lurie Children's Asthma Score, that was developed here about a decade ago, that is used for our nursing and RT-driven weaning. We thought that maybe teenagers were not getting their most accurate exams reflected in our score. Nursing maybe wasn't super comfortable with scoring, especially when it came to the emergency department. And then we were also having some trouble with obese patients not being reflected perfectly in the scoring system. Maybe we were having some trouble with patients who were very tachypnic, tended to be overscored. It was contributing too much to our scoring system. And then going back to other medications that we would give for patients with asthma, there was some new information about Decadron that wasn't incorporated into our asthma CCG yet. And could that be a good way to give patients steroids instead of prednisolone? And then also some confusion around whether magnesium or epinephrine is a good medication to give as adjunctive therapy for our asthmatic patients. So that was kind of how we approached our asthma revision and what we wanted to address in the CCG. So going back to some of the clinical questions, and this is from not only our inpatient service, but also our emergency department and our ICU service. So in the emergency department, what asthma scoring systems have been shown to predict disposition? While we have our Lurie Children's asthma scoring system, that was actually never validated in an emergency department setting. So we were wondering, is there something else that can better capture these patients? And as I mentioned before, we had a lot of questions about whether dexamethasone or methylprednisolone was better for our asthma patients in the ED and those who are hospitalized. Was there any evidence regarding high flow nasal cannula versus NIPPV, especially in our ICU patients? And then for our ICU patients, is there any way we can predict who's going to have a fatal asthma phenotype and who's more likely to be readmitted to the ICU, and how can we address this population specifically? Again, for our ICU, are there any non-inhaled beta agonists that are more effective for these patients? And then questions about magnesium regarding our ICU patients, and then any use in anti-inflammatory effects of azithromycin. And then one of the bigger questions we had, what oxygen targets are good for our asthmatics? And then for high flow nasal cannula specifically, there are questions regarding, is there a flow rate at which we're actually going to have worse albuterol delivery that's going to give poor recovery to our asthmatics? So we kind of put this in a diagram weighing our benefits of implementation and how much time would be needed to implement all of these questions we were wanting to address. So the things that we decided would have the least amount of investment and the most benefit were making a controller algorithm, talking to our case managers and our interdisciplinary rounding team about prioritizing asthmatics, especially about what controllers are covered so we can get their discharges expedited, clear escalation guidelines for our floor teams and our ED teams, and actual concrete guidelines about when to consult our pulmonology colleagues. What we thought was going to benefit our population somewhat, not cause that much investment, was education around our asthma action plans, both to the providers, the nurses, the respiratory therapists, and all of our other team members who are involved in caring for our asthma patients. And then things that we thought would be very beneficial but take a lot more investment, and we weren't sure whether or not was actually feasible given our time course for the asthma CCG overall, was updating or replacing the Lurie Children's asthma score, addressing a PICU population since we did not have a CCG in place for our PICU population specifically, automating LCAS based on documentation nurses did elsewhere in their charting, and then a controller insurance formulary. So to start with our asthma CCG overhaul, after we asked all these questions, we had to do a primary literature search to address them. So using our asthma search terms, we found 412 articles that we pulled for title and abstract review by a team of providers, nurses, respiratory therapists, educators, and pharmacists. And we did this through JBI summary, which allowed us to just really easily look at the title and the abstracts and determine whether it was worth our time to investigate this literature further. So from there, we went through the literature review, and when we had 2 reviewers agree that an article was worth investigating further, we would put that in the category of articles that we would review in full. And then we narrowed this down to full text review of 166 articles, which is quite the big amount to do. We had a team of about a dozen people reviewing all these articles. And then of the 166 articles that we went through, we narrowed it down to 21 that we thought were appropriate to include in our asthma CCG revision and had good evidence. So the big concepts that we took away from this literature review, the first is a really big change for us, and that 2 doses of Decadron 24 hours.
Kita mau tidur kan?
So 2 doses of Decadron 24 hours apart decreased ER length of stay and admissions compared to prednisolone BID for 5 days. So not only is this easier for families, it was also easier in terms of prescribing things for discharge because we don't have to worry about prescribing a medication after they're home a lot of the time. Patients given Decadron had shorter length of stays than patients who were given prednisolone. ED to hospital admission is reduced if there's inhaled anticholinergic agents in addition to beta-2 agonists, as well as administration of IV magnesium. And then use of an RT-driven score-based pathway for initiation and discontinuation of continuous albuterol is safe and effective, and it improves outcomes. If we add high-dose budesonide rescue inhaler, it decreases the risk of severe asthma exacerbation and decreases total systemic glucocorticoid exposure. MDIs with spacers are just as effective as nebulizers, and it's much more cost-effective. And then asthma education significantly reduces readmissions. So how did we incorporate this information into our asthma CCG that we revised? So this is just a broad overview of our new algorithm that we made. So I'll take it by section to explain our changes further and how we implemented the results of our literature search into this revision. So for our inclusion and exclusion criteria, we changed our inclusion criteria to current asthma exacerbation. Previously, it had only included patients who were greater than or equal to 2 years old and had a current asthma exacerbation, or if it was their 3rd episode of wheezing, if they were less than 2-year-old. There's been more evidence over the past few years and understanding that it is very possible that patients under 2 years old have asthma. So we were doing a disservice to our younger patients, not including them as part of the CCG. We also added an exclusion requirement if patients were on home oxygen therapy, because we know that these patients have different physiology in their lungs and probably were not captured as well in our weaning algorithm targeted at people with more normal lung physiology. Oops. Next, we removed our initial LCAS score. Previously, we had an initial LCAS score in our inpatient CCG that had different cutoffs for our scoring system than our normal escalation and weaning pathway. That was creating a lot of confusion, and people were not necessarily being weaned appropriately based on this initial score. So we just standardized it across everything, and now we had the same scoring cutoffs for when the patient first arrived to the floor as we did when they were, on their first Q2 wean or their first Q4 wean. And going into that, we updated our LCAS ranges. So we had realized beforehand that we were lagging behind a little bit of our peer institutions on our length of stay. And part of this was because we were being a bit more conservative with when we were weaning patients. So with our updated LCAS ranges, we were able to expedite weaning, and we made sure that they were more on par with our literature review of different asthma scoring systems and when they would be weaning their patients on those. The other thing we did was we had previously had this criteria that if a patient scored a 3 in our LCAS, they wouldn't be weaned at all on our scoring system. And we realized that was also contributing to increased length of stay, and it was not compatible with the known asthma pathways from other institutions. So we got rid of that, and now the only thing that prevents weaning is if they're needing a very high oxygen requirement, and that makes their qualify in our oxygen category. We also expanded guidance on treatment pathways. So as I mentioned, one of the big takeaways from our literature review is that Decadron has very good evidence compared to our prednisolone and methylprednisolone. So we went ahead and made Decadron the preferred steroid. We also prefer PO to IV because keeping children on IV medications also will prolong their length of stay. We also wanted to encourage PO intake because making our patients and PO would make them get behind in their intake and would also delay discharge, just because even if they were ready from a breathing perspective, they maybe weren't taking enough by mouth and they would need to stay for IV fluids and nutrition. We also added a criteria in our continuous algorithm that if they were on continuous for a prolonged period of time, like 12 hours, we would want to trial albuterol every 2 hours to see if they would tolerate it, just because we would have patients stuck on continuous for very long times with no de-escalation pathway. And we found this to be a way to kind of expedite their weaning plan. One of our biggest changes with the release of our asthma CCG was making a controller guide. This has significantly reduced length of stay, as I'll get into, and really decreased the burden on our pulmonology colleagues with consults regarding controller therapy. So our pulmonology colleagues helped us put this together. We are having our inpatient teams complete our action plans for our asthma patients much earlier during their admission, which is allowing their education to happen earlier, because as our literature review showed, education really is important for reducing readmissions. So we'll get these patients very thorough education earlier, and they're getting discharged earlier in the day so that our asthma educators are able to see them and the education isn't falling on the nurses at discharge. All patients are now going home with a controller, which has also been a huge success in decreasing readmissions. And then we have also decreased pulmonology consults, and that's really lessened the burden on our pulmonology colleagues and expedited consults for those patients who do actually really need a consult from them, because maybe they have a different physiology or aren't fitting quite into our controller guideline. So we put on our controller algorithm the criteria for when we would want pulmonology to be consulted. So we still always consult them for PICU admissions if the patient's already on a very high dose controller and that's not adequate, or if there's a patient who maybe just doesn't fit in the mold. Also, if we feel strongly about smart therapy, we would consult pulmonology. What smart therapy is, and as I mentioned in the literature review that we did, if you have a rescue inhaler that includes a steroid, that can decrease emissions. Unfortunately, we were not able to incorporate this into our standard pathway due to insurance reasons. It's very hard to get insurance to refill an inhaled corticosteroid enough times that the patients can actually use it for rescue therapy. So in the case that we do have a patient whose insurance is willing to work with us, then we would need pulmonology to help us with those smart therapy guidelines. We also updated our medication tables that standardize among all of our units. I went over our inpatient CCG because that's where I work, but this is also present for our emergency and our PICU colleagues to see. So it's just standardized medication doses across all of our units. We also made updates to our asthma action plan so that it would be clearer for families. We made it a pictogram for all patients so that they can see pictures of their controller and then pictures of their spacer. So it shows the spacer either with a mask or a mouthpiece, and then the color of the controller and what it'll look like depending on which inhaler it is. And then we standardize how many doses of albuterol we're doing across all weights. So it'll always be 4 puffs in the green zone, 4 puffs in the yellow zone, and 6 puffs in the red zone. And the red zone would be where they're taking their child into the ED. And then instead of having differences in how many puffs of albuterol we would tell the patient to do at discharge and how many puffs of albuterol we would tell them to do in their normal sick plan, we standardize that to always doing the 4 puffs in their yellow zone at the time of discharge. So these are our results, and I'll just point out different time points in our asthma CCG revision that led to a decreased length of stay. So our overall decrease was from 2.26 days to 1.1 days. So we halved our length of stay for our asthma patients and really got our length of stay on par with other well-regarded children's hospitals, which was a huge success story for this asthma CCG revision. So it all started, there was a CCG revision before my time that was rolled out in 2023. And we had our Q4 out the door initiative at that point. So sending patients home after the first Q4 albuterol significantly reduced length of stay. And we had targeted asthma rounding around that time that also really significantly decreased length of stay. Now, when I came on with our asthma revision, we did roll out our controller algorithm before we rolled out the rest of our revised CCG. So as you can see, around the time we had that controller algorithm released, we had a huge decrease in our length of stay after we had had a prior uptick, after our Q4 out the door initiative had kind of gone from people's minds. And then we had a little bit of an uptick again after our controller algorithm release to when we released our updated CCG with all of the revisions I just went through. And we did a lot of targeted rounding with nurses and providers to try to give them the most education about our revisions as possible to decrease our patients' length of stay. So even though that was a big success, we realized that our LCAS score, our Lurie Children's Asthma Score, is not meeting our patients' needs. We've especially run into problems with our patients in the emergency department and nurses there not being familiar with LCAS and that leading to delayed scoring system. And one of the big things is we really want to standardize our scoring system across all 3 units that see asthmatic. So emergency, inpatient, and ICU. And our current LCAS score really does not encompass patients who are needing such high level of care that they would go to the ICU. And obviously that affects both not only the ICU, but also affects our emergency colleagues. So we were doing research to find what scoring system could we use that encompasses all 3 of these units and better leads to adequate and accurate scoring of our patients and allows us to tie all of those units together. So we settled on the Pediatric Asthma Score, which is a nationally validated scoring tool that is validated in all settings, including the emergency department and the PICU, unlike LCAS, and it will allow us to better integrate all 3 units. So we are currently modifying the PASS, and we added a score of 4 in all of our categories, which I won't go into because that's a whole other talk. But it will give us better transitions when our patients are moving, from the floor to the PICU or moving from the ED to the PICU, and will really allow us to better care for our patients across all of the units. So we're hoping that that will lead to even better outcomes for our patients and especially decrease our length of stay for patients who require a PICU stay. So we are hoping to roll that out before our next asthma season, starting in late fall. And hopefully I can give you updates on how that's improved our patients' care next year. So I would love to take questions at this point about our asthma CCG revision.
Thank you, Shira. That was great. So I yield to the floor for questions. You have to have some. I have some.
Yeah.
Anyone online have questions? You can enter them in the chats. All right, Anna, you'll let me know if anything goes there. All right, so one of the things, as a researcher, I'm always thinking about, all right, so where are we? What are my questions? So my questions about this specifically are transitioning over to the PAS, right? And so when I think about our patients here, we have a population that's unique to the Chicagoland area, which is where we're located. For those of you who are are participating in this from out of the country, and we have a very heterogeneous population that we provide healthcare services to. So when we think about the heterogeneous population and the equity that we heard from the talk before, and we think about the PAS, so I'm wondering how we can use our asthma CCG once we transition to the PAS to compare patients that present here at Lurie Children's to patients that present to other national children's hospitals or community-based hospitals in terms of severity of illness, length of stay, treatment, all that stuff. That's a big question.
Yeah, I'll address that in part. So first of all, when we're doing our transition over to PAS, we are comparing it to our current LCAS scores, of course, to see what scores correlate to each other. And obviously with the goal of integrating our new cutoffs into the CCG that we just revised, but also that'll give us the ability to compare how our population compares to other hospitals and what scoring cutoffs they use for their transitions between units, their escalation and de-escalation from continuous to Q2 albuterol. And with that, I think we can also in the future go back and take our data and our cutoffs, and also when we're able to wean patients in terms of how long they've been there, and compare that to other similar children's hospitals, because we do have a standardized score. And it'll allow us to make some of those connections about, okay, how do our populations differ? What makes, our patients able to either wean faster, wean slower, or maybe they, need a different cutoff because something is different in their genetic makeup and their social status that makes them, need longer time on higher, level of care, such as continuous albuterol, or they're able to wean faster due to some other circumstance.
Great. So we know social influences of health really impact asthma diagnosis and outcomes. So is the modification of the PAS based on different patient populations or only on the LCAS?
So the modification that we're doing allows us to actually go higher on the scoring system than the standard published one. And that's going to allow us to really encompass our ICU patients better. And I think that will lead to better integration for our patients who do have these really high social risk factors for bad asthma, because a lot of the time these patients come in sicker. And our score will be better able to distinguish that they are these sicker patients who need more aggressive care.
Great. Others? Okay, very interesting topic. And thank you, Shira. This was really a great presentation. I think we have a break next for 5 minutes or so.
Thank you.
That was really great. Thank you. So yes, we have a break until 10:45.
Okay, because sometimes I think.
Welcome back, everyone. I hope you had a great break. We're going to go ahead and get started with our next speaker, Dr. Jonathan Wanta, who is a child and adolescent psychiatrist in the Pritzker Department of Psychiatry and Behavioral Health here at Lurie Children's. He specializes in emergency psychiatry and caring for patients boarding on the medical floors here at the hospital as they await psychiatric hospitalization. So Dr. Wanta is going to talk to us about autism and developmental delay proactive care, clinical care guideline. Dr. Wanta.
All right. Everyone hear me okay? Cool, wonderful. Thanks for being here, everyone. See a few familiar faces in the audience. So yes, over the past, oh my goodness, I think it's almost been like 2 years now. My partner and I have been working on the autism and developmental delay proactive care clinical guideline. Just went live a few months ago and has been a really interesting process, learned a lot, and still have a long way to go to kind of make sure it's taking best care of our kids that we can while they're here at Lurie Children's. So just a quick little outline. We're going to talk a little bit of a background. I know everyone's here from diverse backgrounds, so I want to make sure that we kind of have some sense of some key terms that we'll be talking about during this presentation. We're going to go through some of the quality improvement methods that we really utilized while we were working on this clinical care guideline. I'm going to tell you a little bit where things are currently, and then maybe talk about what kind of next steps we need to work on to make sure this is really the best it can be. So in psychiatry, pretty much across the nation, we have a boarding crisis. So essentially, since even pre-COVID, but definitely exacerbated by COVID, we've seen massive increases in pediatric patients presenting to emergency departments with mental health complaints. At the same time, there has not been an increase in inpatient psychiatric beds. There has not been a huge increase in outpatient services. So really, there's quite a mismatch in the current state. So what ends up happening then is up to 50% of patients who come to the hospital and require inpatient psychiatric hospitalization have no place to go. So they board. Boarding is essentially that you're keeping a patient either in the ED or on the medical floor until something opens up. I think we're pretty lucky here at Lurie Children's. That's usually in the hours to days category. I have colleagues that will tell you sometimes it's days to weeks. And certainly if you look in the literature, there are cases where kids are in the hospital for months waiting to get to psychiatric treatment. Here at Lurie Children's, we primarily board kids on the medical floors. Sometimes kids may board in the emergency department for a few hours. But really, I mean, there's kind of pros and cons to both scenarios, but just kind of our standard of care here is on the medical floors. There are a lot of factors that go into who boards and why they board: insurance, race, ethnicity, gender, diagnosis, complexity. There's actually this concept of reverse triage in psychiatry care, where the most sick patients actually have the hardest time getting into psychiatric care. And among that population of kids who are reverse triaged are often kids with autism spectrum disorder, which is in and of itself an independent risk factor for prolonged boarding times. Little background on autism. So autism is a neurodevelopmental disorder. Essentially, what that means is that it kind of starts in childhood and develops over time. We use the Diagnostic and Statistical Manual of Psychiatry, the DSM, to diagnose children with autism. And there's two main buckets, or two main criteria. Criteria 1 being that there are deficits in social interaction and communication. Bucket 2 is that patients will have repetitive or restricted behaviors, interests, and activities. Autism is called a spectrum disorder because there's a wide range in how kids present and the level of functional impairment. So for example, with that first criteria, deficits in social interaction and communication, you have some kids that just don't understand sarcasm. And then you have other kids that are not able to like form words, they're nonverbal. Some kids can use communication devices to get their needs met while other kids really cannot. Very wide spectrum. With the second criteria on the restricted interests and behaviors, You have some kids that can tell you everything that you would ever need to know about trains or dinosaurs. And other kids will kind of walk around like flapping their hands, pacing, rocking as like one of their repetitive behaviors. And really, it's just depends on that individual patient. It's kind of very specific. And you can't just make sweeping generalizations about all kids with autism because it really is pretty unique. There's no specific single known cause for autism. It's suspected that there's some genetic and epigenetic etiologies. That being said, we've seen this increased prevalence over time. So I think, years ago, you might have seen a 1 in 100, and now we're saying about 1 in 36. Due to a few different reasons. One, I think, is better recognition of autism, right? We know what we're looking for. We know how to diagnose it. And number two is that, like I mentioned, the spectrum is really increasing. So maybe some kids that would not have been diagnosed with autism in the past because their symptoms are more mild might be kind of characterized as like an autism level 1. Translating care for autism, I think, is interesting and it's challenging all at the same time. Like I mentioned, everything is quite individualized for care, right? So sensory needs are individualized, communication is individualized, and that takes time. It takes a lot of hard work. And I think patients and families are kind of constantly reevaluating where we're at, where our goals are, and where are we going with some of this. At the same time, escalation triggers can be quite different between different kids. Maybe one kid loves walking around banging pots and pans, and another kid, if he hears a loud clanging noise, he's going to get dysregulated quite quickly. So here at Lurie, for people who are joining remotely, just some background, we're a 360 plus bed quaternary care hospital in an urban setting. In the emergency department, we see about 1,300 kids per year who are here for a primary psychiatric chief complaint. We see kids in the emergency department up on the medical floors. We have quite robust outpatient services with different levels of care. We have a 12-bed inpatient psychiatry unit. And just this past December, we opened a 4-bed unit kind of specific for kids with neurodevelopmental disorders who need kind of more of that behavioral therapy. So as you can imagine, kind of a lot of overlap with the population that we're talking about today. A little bit old data at this point, but from January to October in 2023, there were 53 patients with autism who were boarding on the medical floors. Almost all of these patients were boarding with a chief complaint of aggression or agitation. The behavioral response team, BRT, responds in crises. They call BRT stats when there's an acute behavioral concern on the floors. During this time period, there were 107 BRT stats, and 2/3 of them were for kids with autism. So as you can see, it's a huge concern and can be a strain on resources here. When patients are boarding here at Lurie Children's, like I mentioned, they typically board on the medical floors. They are typically admitted under the pediatric service. So they're going to have a pediatric hospitalist as their primary. Psychiatry follows very closely. We typically see these patients every day. We try to provide as much psychiatric care as we can on the medical floors, but as you can imagine, a medical floor is not a psychiatric floor. I think that's a theme we'll come back to multiple times today. So we try to provide the best care and medication adjustment that we can. And then there's a huge multidisciplinary effort. So we have sitters and nurses who are at bedside basically 24/7. We have the behavioral response team that we talked about already. We have child life, occupational therapy, speech therapy, security sometimes that get involved to help keep these patients, their families, and our staff safe. So the challenge comes in that medical staff have overall less training and less experience working with patients with autism compared to, say, staff that are on an inpatient psych unit. A medical floor is typically optimized for medical care. So you have lots of tubes and wires and buttons that you typically would not have on an inpatient psych unit. This can lead to staff injuries. It can lead to moral injury. It can lead to demoralization. Caring for this patient population that really isn't getting the level of care that they need and that they deserve. And I think finally, I want to kind of highlight the unclear and inconsistent role expectations. Who's providing what care? How are we rising to the highest level of our training while also providing safe care that we feel comfortable with? So to summarize, we came up with the problem statement, right? So here at Lurie Children's, there was no standardized pathway to understand and address the unique care needs for children with autism spectrum disorder, intellectual disability, and or just an unspecified developmental delay who are presenting to the emergency department or the medical floors, and they're at risk for aggressive behaviors. We're going to kind of go through this a little bit more detail and kind of unpack this as we go. So in October of 23 or 24, wow, the time flies, we applied for support from our Center for Quality and Safety, and we were fortunate enough to be paired with a consultant in basically QI expertise that was able to walk us through kind of this process for how to kind of deliver on this problem statement. So I'll kind of go through each of these one at a time. So project initiation started with, I would say, 3 main buckets. Number 1 was identifying our SMART aims. So from the bat, we really identified that intramuscular medications given for acute behavioral crises and physical restraints that are sometimes required to keep patients safe when they're in imminent harm to themselves or to others, that was kind of our key metric. So we were hoping to reduce intramuscular medications and physical restraints by 25% over 6 months after rolling this out. We had some secondary aims as well, really looking at like staff comfort and confidence, looking at the patient experience via the parent experience. But really our primary goal was like those interventions at bedside. For the inclusion criteria, we wanted to include patients with a known or suspected diagnosis of autism, intellectual disability, or developmental delay. You know, I think parents have a good sense of my child has some special needs that they might need extra support here in the hospital, but they may not have that diagnosis, especially since I mentioned before, you know, a lot of services for psychiatry are lacking. We also wanted to really, at least initially, kind of target patients who are at risk for aggressive behaviors. I think there's a lot of kids with autism who do not have aggression or may not need extra help coping during their hospital stay. And just kind of given our limited bandwidth and resources, we wanted to focus on like the highest risk patient population. We included patients on the medical floor and in the ED. We included patients that were here boarding, but we also wanted to include patients who were here just for other medical stuff, right? So kids with autism get asthma, they get epilepsy, and they're here for lots of different things. And they may also kind of be at risk for aggression, even if they're not here boarding. I think the main exclusion criteria was that we're not an inpatient psych unit. So they have a different staff, different treatment goals. So we kind of excluded the inpatient psych unit from our CCG. And then finally, at project initiation, we focused a lot on recruiting key stakeholders. I just told you that we are including almost the entire hospital. So as you can imagine, we included a lot of key stakeholders, a lot of different specialties from different floors. And I think kind of getting those different inputs was really helpful at every step along the way. So step 1, we kind of started with a rough analysis, our current state analysis for what actually goes on for a kid who presents to the emergency department. And I think hopefully it's a little too small that you guys can't read it. I don't want to walk through it kind of step by step here because I don't think that's the key takeaway for me. I think the key takeaways here are that this is complex. This is dynamic. You can see some dotted lines. You can see some arrows that go both ways. You can see that there's like 412 different providers listed here. We had to color code things. there's a lot going on. And, you know, especially for a population like this, a lot of what we're talking about is pretty hospital specific. Different hospitals may have different specialists around or may have different procedures for how to help these patients. We went over several drafts with this and wanted kind of key stakeholders involved, because this next step, we see a lot of yellow starbursts now, right? So yellow starbursts, I was taking notes on this before, and I wrote these were problem areas, and then I reframed it, opportunities for improvements. So I think, as you can see, almost like every spot along the way, there's some opportunities for improvement in care. And again, this goes through several iterations with different stakeholders, kind of figuring out what are some of the targets, areas where things are not going so well. From there, we started to develop a fishbone diagram. So fishbone diagram, we kind of started with our outcome or our problem statement on the right, and then try to start generating different things that were going wrong, similar to the last slide that we looked at, just in a more kind of organized way. I think of the fishbone as being more of a diagnostic tool, right? Where kind of the boxes in color are sort of the larger buckets, and each of the different spines of the fish are kind of different problems that we were encountering or kind of certain challenges that we were running into. Pretty early on, we recognized that we needed to divide our project into floors and the emergency department, just since kind of the goals of those two environments are quite different. So you're kind of seeing like page 1 of the floor fishbone diagram. At this point, we're keeping things pretty broad and exploratory. It's really just a lot of brainstorming going on at this point. It helps us organize our hypotheses. We want to avoid just simplistic gut reaction explanations or solutions. Again, coming back to the system complexity and really thinking about all the different contributing factors. From the fishbone, we were able to generate a key driver diagram. So if the fishbone is more diagnostic, I would say the key driver diagram is more action-oriented or more treatment-focused. We're pivoting from what caused the problem to really what levers can we realistically pull in our current system to improve outcomes. So again, we have the key drivers as those similar bucket items. Each of these bucket items may have multiple secondary drivers. From the secondary drivers, we start to think then about interventions, and interventions can affect one or multiple secondary drivers. The key driver diagram is specific, it's strategic, it's operational. I think as we were going through this process, we had color-coded things. So if we had a good intervention that we could work on, we'd color it green, kind of once it was successful or once we had a plan laid out. Yellow, red interventions, as you can imagine, are kind of cautious or like no-goes. So we actually had two pages for our key driver diagram for the floors, and then another whole key driver diagram for our emergency department. So, and this was my first kind of in-depth foray into QI. So the question then was how to turn kind of this QI framework into a usable system for our hospital. And that's kind of where we started organizing our clinical care guideline. Clinical care guideline needed to be familiar, right? People in Lurie Children's all know we have these clinical care guidelines. They look a certain way, they have a certain flow to them. They have resources and links. So how do we kind of take this QI work and turn it into something that we all know and love here at Lurie? We also wanted to translate some best practice guidelines just from autism care in general into our CCG, and then also thinking about the evidence base. So I can tell you there's not a lot of research out there about caring for kids with autism on the medical floors. This is something at our annual meetings There will be like 1 or 2 presentations the entire week, and everyone kind of goes to them because they're interested and they want to hear more. I was fortunate enough to work with a psychiatrist at Dayton Children's who had kind of worked through a sort of similar process. But again, Dayton Children's is different than Lurie. So like, what can we use and borrow, and what do we need to kind of make for ourselves? A few categories of interventions or takeaways from the CCG. So I think number 1 for me is early identification and intervention. You'll notice that it was the proactive care CCD, because over time you really thought about what do we do to get to these patients, give them the supports they need before they get to physical aggression. So how do we identify patients who are at risk? What interventions can we deliver early? And hoping that has long-term payoff. And I'm actually working on a grant project right now looking at kind of from a research perspective, identifying risk factors for aggression as well. Pretty much across the board, interdisciplinary communication was one of the most important things that we heard about and we talked about. Through early identification, we're able to think about, okay, this patient may be at risk. How do we communicate that risk to people who need to know? How do we get Child Life? How do we get the behavioral response team to come see this patient and maybe do an early check-in? Something that we're still kind of working on in this process too is, are huddles helpful? Are huddles an extra burden on hospital staff? We want to make sure people are on the same page and know what our goals are for the day. Especially if it's kind of preventing staff injuries and keeping our patients safe. And then last but not least is thinking about the validated measurement tools. This part I got really excited about because we do have some data there. Specifically, our sitters who are with the patients 24/7, they complete the behavioral activity rating scale every hour. It's a 1 through 7 validated instrument that's supposed to help decrease escalation events. We have the modified overt aggression scale. This is what our psychiatric social workers are using in the emergency department. It gives us a standardized instrument to see between visits, what's your aggression score. If a child's score was 50 2 weeks ago and today it's 70, well, we know that it's getting worse. Sometimes it's hard to put numbers on aggression, but with standardized scales, we're able to do that. And then finally, there's the dynamic appraisal of situational aggression, the DASA, which the psychiatrist is filling out daily on the medical floor. While patients are boarding, often we're trying to deliver treatment. So, if a patient's DASA is 777, we get an intervention started and they're decreased to a 5. It's a small win, but it's again an objective instrument that we can see that children might be improving. So I would say now we're kind of in the sustain phase. We're getting some ongoing meetings with key stakeholders to really figure out what's going well and what needs to be updated. I had mentioned earlier that the huddles, like even thinking about what time of the day works when you have nurses who have morning meds to give, but then you have case management rounds at 11 and psychiatry has rounds until 10. It's like a puzzle trying to put everyone together to kind of figure out when a huddle might be helpful. We've collaborated with the Family Advisory Council to see, what language makes the most sense for your patient. I think saying, does your child have aggression can be quite stigmatizing for families, I've learned, where does your child have a history of aggressive behavior? It might feel a little bit safer and kind of still get the same message across. Continuing to integrate with EPIC has been really important too. All of the scales that I mentioned are in EPIC, which has just been a huge lifesaver. One of the interventions that we have is the getting to know me tip sheet, right? Because we mentioned kids with autism all have such specific needs and sensory capabilities. So does it make more sense to have a paper copy at bedside, or does it make sense to have some kind of form on EPIC? I think if you asked a room of 10 different people at this hospital, you get 10 different answers. So it's hard to kind of translate that to a CCG. And then education, I think is just so important. I think there's been some variability across the hospital, like with different units and kind of the uptake of this. We want to standardize individualization, right? Because our patients are unique versus like what's the standardized versus individualized care. And especially thinking on weekends and overnights, our hospital functions 24/7, but that doesn't mean that everyone's here 24/7. How do we make sure that these kids are still getting good care, even if it's Sunday morning? And that's it. Just a few minutes.
Thank you, Dr. Wanta. That was great. I guess
one last thing. Sorry, maybe I can pass this around. This is like the official CCG. I think it's the most up-to-date one. Again, not to like look through kind of all the different things, understand it all, but just kind of understand the complexity of it. And then the last few pages are some of the scales we mentioned, some of the things that we are providing to patients and families at bedside. So just kind of take a quick look and see kind of what we've been working on.
great, thanks. So I'm going to open up to the floor for questions.
Should be similar. Thank you. Yeah. Hi, thank you so much for your presentation. It was really great. And I just have a question for your last slide, education, education, education. So how, there is a lot of work that goes into the CCG, and I imagine a lot of key stakeholders. And in order to be successful, to get that education and the buy-in. So how do you approach that to get that education out to everybody? I think you had a statistic of just 100 plus providers, let alone the nursing and the allied health team, et cetera. So how do you approach that?
Yeah, I think that's something that we definitely struggled with. I think as a clinician kind of entering now into like a completely different world of not just educating clinicians, but also like other nursing assistants and nurses, it was really difficult. What was helpful was kind of having a few key stakeholders who were able to kind of send us in the right direction. I learned a lot about nursing committees over the past few months that I did not know existed. And I admit I could have like navigated that better and kind of been more aware of some of these things up front. But like nursing committees are like disseminating information to different people. And we kind of took this approach of like, if someone wants to hear about this, great, we'll be there. We created one-pagers as well. So kind of a one-pager for nursing assistant and a one-pager for nurses. So these are some of the key changes that we might be asking you to think about. And then I think in the moment education, and I mean, my personal favorite, but when I go to bedside in the mornings, I make sure I pull up the CCG. I make sure I talk about the different elements. Make sure I talk about the BARS assessment. I make sure I talk about the escalation event documentation, just so people know that it's there and they can have those resources if they're helpful.
Thank you.
So you talked about a lack of common language, and we've been working really hard on the medical side, teaching the well class with the red scale. Are you familiar with that?
The disruptive, destructive,
Yeah.
dangerous.
To kind of form that common language. So I think we need more work in that area too.
For sure, yeah.
But shoot, I forgot my second point. There might be something better out there, so it would be worth looking into. Was nursing very involved in this? Because I feel like the education really struggled at the nursing CNA level.
Yeah, we did have nursing, like some of the floor leaders, like 21, 19. I honestly wish we would have pulled in like a nursing leader along with my partner and my CQS consultant, like right from the get-go, honestly. And I never would have even thought that was like an option or something I would have considered or should have considered. But I think in retrospect, kind of having someone from day one would have been helpful instead of like stakeholder meetings are great, but we also had a lot of meetings, kind of just the three of us. And I think having nursing input would have been helpful at that point.
And then the BRT team, like, I think in the moment education is the most valuable too. So I love that you said you're doing that. But I also kind of had an expectation that the BRT would do more of that. So I don't know if you've been working with them in particular. They do end up doing a lot of it and making suggestions, but I don't know that that's a part of their regular routine or expectation.
Yeah.
They may, if they identify an aggressive patient, they make rounds. And they try to make rounds every morning and every evening. So I think that piece is great, but a lot of times they come by and say, oh, how's it going? And it's going well in that moment. And then it takes having to call a BRT stat and go through the whole de-escalation or the whole crisis before we start getting more information on how to prevent it. And I think that's the piece that nursing is really missing, which we do a quick overview in the WELL class, but we don't do enough there either. So ideas for future.
Yeah, I mean, it's great to know too that like, there's such an interest in this too. I mean, of course, like an ounce of prevention, it's worth a pound of cure.
I just wanted to piggyback on what you were talking about. As somebody who works in the single ventricle space, I love what you're doing. A lot of our patients, have autism, and the frequency is increasing. And as our patients are coming in and out of care, and I always struggle with like how best to serve them as they need to be integrated into the ICU. And it is an unsafe, environment, and how to practically partner. So I love this education. And I would love to understand more how to help support our patients and families as they are entering, so that there isn't this aggression, support. So beyond the ER and the boarding and in the global chronic care medicine, I would just love to understand more.
I mean, I can't even imagine outpatient practices where it may just be you, the provider, in a room by yourself too. Like we have some satellite clinics. Yeah, I think this is just the beginning.
The tip of the iceberg.
Hi,
Also, sorry.
that's okay. Did you want to?
Is there hope for more expansion in the outpatient side? Because I feel like we diagnose these kids here, but we're missing that key piece of therapy.
I am not personally involved in this realm. I know our autism unit that just opened. You can provide great care for the duration of the admission, but if you don't have the behavioral therapy when you leave or your medications being managed by someone, it's kind of all for naught. So I know that team is working on it. I don't know the specifics of kind of where things stand now.
Thank you for your presentation. My name is Reed. I'm one of the nurses in developmental behavioral pediatrics, as are two of my coworkers. And I do think, or I wish if I had my magic wand, I do think there's work to be done with more of a collaboration in our department and in psych. I think we both have things to offer each other. I don't know if you have thoughts on that.
I would love to. I know we had reached out to someone from DevPeds who was going on maternity leave right when this project was starting. But yeah, I mean, you guys have a wealth of information, stuff. That'd be lovely. So your name was Bree.
Bree.
Okay.
So there's obviously some significant interest in this. And let's see, do we have anything in the chat? There's a comment in the chat that says, I'm a nurse with the outpatient group, developmental peds at Lurie, and additionally work with WELL training team for inpatient nurses. For years, inpatient nurses would ask things like, what do we do about autism during WELL classes? So I wanted to say this was a great start and would love to help move your project forward and think through the education piece, share resources from outpatient to inpatient too. So it looks like you have some collaborators who are willing to step up to the plate for you.
Is my email included on this at some point? I don't think I have it.
No, but we can put it in the chat.
Great.
When I step back down. The other thing that I wanted to say is it's obviously so people are really interested in this, and everybody in this room, I think, is a nurse, correct? All right, so there is, as you well know, this is something I don't probably have to tell you, but autism touches the work that the people in this room and online do probably daily. And so having the knowledge and the strategies and the processes to manage those patients, I think only makes the care that we deliver better. And so this is a welcome CCG for sure. And there are very clearly some opportunities for people to continue to participate and contribute to its next version, whenever that's going to be. I know this just came out recently, so I know there's some strategy for timing of versions and things like that. So when we think about this, and we know that there's patients all over that have these challenges, how do you measure our contributions to reducing the initial goal that you talked about, the 25% reduction in IM meds and one other thing?
Physical restraints.
Yeah, sorry, physical restraints. How is that going? Because the CCG has been active for 6 months now.
Well,
Sorry.
we have been still trying to get baseline data. Some challenges there. So once we have baseline data, I think we can have follow-up data then. So I don't have any data to share yet, unfortunately.
So that's a really good point, because it brings up the point that we talked about earlier with the application of the asthma CCG and understanding, and all the other CCGs, understanding who the patient population is first and being able to accurately identify them in the electronic health record so that we can, with ease, identify how we're actually improving the care delivery model that we have. And so it's very clear, especially given the intricacies of autism diagnosis, how challenging the identification is for these patients. Other questions? All right, well, you have an interested group here, so.
Great questions, thank you.
Great, thanks, Dr. Wanta.
Thank you, everyone.
All right, so now we have another quick break, and we will reconvene at 11:30 local time to talk about insulin management guidelines and implementation. Thank you. That was great. Welcome back, everyone. Thank you for sticking with us. And I just realized that I never introduced myself at the very beginning of the morning. So my sincerest apologies for that. So I'm Lauren Source. I co-direct the JBI Precise Center here at Lurie Children's with Dr. Audrey Rosenblatt. My practice over the years has been pediatric critical care as an advanced practice provider, and I now serve as the Senior Director for Nursing Research and Operations here at the hospital, along with the co-director of the JBI Precise Group. So welcome back again, and I would like to introduce our next two speakers. So Dr. Elizabeth Dobler is a board-certified pediatric hospitalist and informaticist. She has over 10 years of experience in clinical decision support and currently serves as the medical director for clinical decision support here at Lurie Children's. And Dr. Sean DeLacy, who completed her resident internal medicine pediatrics at Indiana University before coming to Lurie for her fellowship in pediatric endocrinology. She's now faculty in pediatric endocrinology and serves as the clinical practice director for the division, while also participating in health services research in both types 1 and 2 diabetes. So welcome to both of you.
Great. Hi, guys. I'm going to go first. I'm Sean DeLacy. Welcome. So this is just kind of basically what we're going to review. So I'm gonna, as the endocrinologist, I'm gonna talk about diabetic ketosis a little bit, talk about the creation of our initial CCG back in 2020, when I was a fellow, for the clinical care guidelines, then some of the post-implementation challenges of that, and then how that kind of led us to create an insulin dose calculator, and then some of the challenges with that, the cycle. So in terms of diabetic ketosis, so it's kind of a spectrum of how it develops, just as background. So when they're type 1 or even sometimes in type 2, honestly, when there's no insulin production, the glucose can't enter the cells, fat starts breaking down and creating ketone bodies. And eventually those ketone bodies start creating acid in the blood and a ketoacidosis, so we call it. But before that, there's ketosis. And just looking at kind of the impact of DKA, so ketosis with acidosis and ketosis without acidosis. So I just kind of put some things up there. So hospital admissions for DKA cost a lot. They last a long time. They're a big burden on the family. It's 30 to 40% of kids at diagnosis, but also quite a few of them, about 4 per 100 patient years in type 1. But you can see it's about 4 per 100 patient years is DKA, but there's 45 per 100 patient years at age 16 that's other things. And often that's ketosis without acidosis. But there's really not good national data related to ketosis without acidosis. Back in 2020, they created the CCG, and that was for a variety of reasons because of a large amount of variations in practice and how both the ED and inpatient and different endocrinologists were treating DKA, DK-NOA, system barriers in that workplace inefficiencies, particularly in the emergency department about getting some of those kids through. So some delays in identification, some suboptimal treatment, and then some undesired outcomes for the patients themselves. So when this initial CCG, which disclosure I was not part of as a fellow, happened, there was a lot of stakeholders involved in that. So endocrinologists, emergency medicine, inpatient, ICU in terms of physicians, and then nurses from all of those places too. Some dietitians, the lab, patient family experience was involved, analytics, informatics, things like that, a really huge team. And of course, there was like a evidence review as part of that, the PRISMA diagram, not need to go into details, but basically that they screened a lot of articles to figure out best practice and how to take care of both DKA and DK-NOA. This is not meant for you to kind of read through all of it, but it kind of summarizes the evidence base and what's good evidence, what's not so good evidence, et cetera. You can see everything is the best is moderate, and then there's some low. To be honest with you, diabetic ketosis without acidosis, there's almost nothing on there. It's almost all related to DKA because that's what's been studied. So for DK-NOA, which is primarily what we're going to be talking about today, because that's where the insulin dose calculator comes into play. It was primarily based off of international guidelines, expert consensus, observational data, which are obviously lower forms in terms of rigor. Generally, the core principles of ketosis management when you look are hydration, insulin therapy, frequent monitoring, and escalation of care if you don't get improvement of the acidosis or the ketosis. This is the International Society for Pediatric and Adolescent Diabetes, kind of how they say to deal with ketones without acidosis. Just a couple things. One up here, I don't know if you can read it, it's so small on my screen, but it basically says to add a certain percentage onto the insulin dose. So increase the insulin dose by like 20%, 15 to 20% if you have ketones without acidosis, which is kind of a complicated little formula to do. And then to do that every 2 hours until things improve. So what that led to, this is a excerpt from the original CCG. So it was guided by ketone serum levels, so that was new. Every 2 hour corrections in ketone serum levels to kind of try and get these kids to improve in terms of their ketosis quickly, and to increase their short acting in relation to their ketosis. So if they had more ketosis, that usually means they're more insulin resistant and they need more insulin. So we should increase their amount of insulin. So there's this whole little chart that's like, if their beta hydroxybutyrate is 0.7, you should do their sliding scale plus 10%. So you can see where that gets into a lot of nuance in there. The goals was to decrease their time in the emergency department. So they come in, they have ketosis without acidosis. Are we getting them out? Are they coming in? If they're on the floor and they end up having to get admitted, can we get them out quickly instead of them progressing to a drip or having to stay in the hospital? But there were some challenges with that. So best intentions of improving all of these things, but some issues that happened. So it led to a lot more manual dose calculations, which were already honestly happening a lot on the nursing side, but adding some on the doctor side because of adding some of those like 10% increase, 15% increase, some complex decision pathways, as you could see even that little box, and some increased cognitive burden kind of on everybody related to it. So just for an example to like drive that point home. So if you had like a 10-year-old that came in with type 1 diabetes, he has ketones, he has a high blood sugar, he's not acidotic, and his carb ratio, so he gets 1 unit for every 10 grams of carbs, and 1 unit is expected to decrease his blood sugar by about 50. This is what it looks like when the physician goes to put in their insulin order with like a million things that they have to fill in related to that. Like a lot of wild cards where they have to like then add 1 unit or a half unit. And then if they have ketosis, that means they have to go in and then say each of those units they need to increase by 15%. So in addition to going by 1, they were doing this manual calculation where they had to add 15% to each of these units. A lot of math for each of them. So that's on the physician side. On the nursing side, then the nurse sees that order that the physician did all that math for. She says he's eating 20 grams of carbs. His blood sugar is 320. First, she needs to divide the carbs by his carb ratio, gets 2 units. Then she looks at the thing the physician put in. She's like, okay, 320, 4.5, 2 plus 4.5 is 6.5. It's about like 5 different calculations that are happening before that patient gets any insulin. So you can see there was math errors, order fatigue, particularly on the physician side, communication gaps when things would change, frequent order changes, variability in how the physicians would do that. And so in iterations of doing this, obviously it's over time, we do something, we reevaluate. And as we're planning, right, in this circle, we acted and then replanning. Part of that planning process is doing benchmarking, right, against other institutions and what they do related to their insulin orders. And one of the things that we had talked about for a while, and especially, you get fellows in from somewhere else, like we're doing order where we just put it in and we don't do all these calculations. They're like, why aren't we doing that? And that's how I started talking with Elizabeth, who helped me with the next part. We're going to talk about it.
All right, hi, I'm Elizabeth. So back to kind of what Sean was saying. So she very nicely outlines the problem. And so I'm a big fan of not reinventing the wheel. So if someone else has figured out a tool, we might as well reuse it. And so when we have these problems, we often do a couple of things. So one, we look and see what tools are out there. So our EMR has a lot of references and things we can search with the vendor. And then we also can reach out to our partner hospitals that also do pediatric care and see what they're doing. And so through those efforts, we discovered something called the insulin dose calculator. And we thought that would fix all of our issues. But the technology is just one piece. So I'm not going to go into this very much, but I just wanted to show you a quick picture just so you have a sense. So essentially for the insulin calculator, the provider enters your hyperglycemia correction, they enter your carb ratio and your ketone correction when appropriate. The nurse then goes in, enters the time of day, enters how many carbs they're taking, enters how much their ketones are and what their blood sugar is, and the computer does all the math for you. So it'll spit out the recommended dose. So I'm going to talk a little bit about our implementation journey with this. So we'll go through our pre-implementation, some of our go live decisions, and then post-implementation, which is still ongoing. So first things first, when it comes to the design, like a lot of things in pediatrics, things are originally designed for adults. So most institutions were using this and they just used whole units. But as we know, pediatrics, our kids are smaller. So a lot of insulin pens and a lot of patients use half units. So we need to talk about whether or not we wanted to round to half units or not. Speaking of rounding, we also often recommend customized rounding logic for our patients. So less than, so 0.3 and above, we would recommend giving a half dose. Less than 0.3, we give 0. And so the computer doesn't quite handle that yet. So it can only do basic math rounding. So 0.25 and above goes up to a half, less than that goes down to 0. And so we need to have discussions about, one, is it safe to do this since this is different from what we've been doing? And then two, how are we going to handle this when we're educating families one way and the computer is saying something different? And then ketones. So the standard build requires like manual entry of the ketone correction, but that still can be a lot of numbers. So what can we do in terms of the build to make it a little bit easier for providers? So when it comes to these designs, I think a big question is who needs to be at the table. And so me and all my naivete, I was like, well, you know, it's really the providers that are having the big change. And so we should really just make sure that they're involved. But then it became very clear that this is going to affect a lot of workflows across the hospital. So we ended up engaging bedside nurses, as well as our diabetes educators, providers, and then pharmacy, who not only does order validation, but did a lot of the build for us. So I'm going to talk about some elements of our iterative design, just a few examples of things that we went through. So one, it was brought up early that it'd be really nice if the nurses need to enter in their current blood sugar, if they could just see it in the same screen versus having to look at results and then remember it. So we were able to, because this is a lovely computer and a report, pull in the most recent blood sugar so that it's right there in front of people when they're entering this information in. In terms of standardization, so I briefly talked about how we discussed whether or not to standardize the ketones, and we decided to default in the ketone correction percentage that we are recommending on our CCG. It's another item that like is fairly standardized, so we might as well take advantage of it, and then we can encourage people to use the evidence-based percentages. But we also discussed what else we can standardize, and so another thing what we discussed standardizing was our blood sugar targets. So the vast majority of our patients, their blood sugar target is 100. So we might as well default that in. It also serves a little bit as like a safety check, right? No one's going to delete that and enter 10. Whereas if people are a little bit confused, who knows what they enter, which can help a lot. And then as you can see, even though this isn't the 19 wildcards of the last order, I counted them at one point, there's still a lot of fields. So the more we can standardize and default, the better, both from the safety and from a cognitive load perspective. And then there are a lot of little things in terms of just designing for clarity. So things that we often think are simple and obvious to us in terms of like phrasing or ordering are not necessarily accurate for other people. So trying to get feedback on what's the best order for the fields within the order, within the MAR, what's the best way to phrase the different clinical scenarios. So then came education. And so there are a couple of big parts of our education. One, finding out how people want to be educated. And so traditionally we do a lot of epic tip sheets. Sometimes we'll have like example videos. Sometimes our educators will come to like division meetings and do a lot of emails. But people, because this is a new tool and a new workflow, people actually want to practice it. So they really want to be able to practice before we went live. We have a play environment, a practice environment. And so we were able to set that up. During this, we discovered a lot of issues with our play environment. And so we're also working on fixing a lot of those issues so that we can do this more easy in the future. And then came the audience. So once again, initially I was like, oh, okay, we'll just go to our floor that specializes in diabetes care. That's where all these kids are. But it turns out that's not the only place we give insulin in the hospital. We give it everywhere. So we needed our ICUs to know how to do it. We also needed our ED even to know how to do it. So we really tried to reach out to all the groups. Even with that, we ended up missing one group. So we had to circle back with one other small group. And then go live. So this was hard. So we at Lurie have a lot of changes going on right now. And so, you know, when this project originally was set to go live, there was another big project that had gotten pushed back. So it had the same, pretty much the same go live date. So we originally had hoped to go in December, and we're thinking, this is great, let's go ahead. We'll get the standardized, we'll get the technology, it'll be great. But really, this was one major change on top of another. And so people did not necessarily have the bandwidth. And so we also, because of those changes, people felt like it was a bit rushed. So we had to sort of debate the case for moving forward sooner versus later. So we did end up pushing it back a month. So just a month, because we were thinking that we still want to go forward in a fairly tight, quick time frame. But we were able to come up with a little bit more time for the education and give a little bit of space between those two large interventions. So post-implementation. So we went live, and there were a lot of things we didn't know. So there were clinical scenarios that we were not anticipating. And so we needed to go in and update the tool for that. As we were updating the tool, there were multiple versions. And so we needed to make sure that we were balancing how many different versions of the tool for this customized clinical scenarios versus how easy is it to actually access those and find the correct ones. And then along the lines of finding the correct ones, we also discovered that we are working on standardizing a lot of our orders, and we are not there yet. And so our insulin orders are in a lot of different order sets, and the groups that they're in are not standardized. So we would update one group and update one order set, and then it would turn out, oh, the CCU has another one. So through this, we've sort of as well as just a larger project in general, this institution, we're working on actually standardizing some of our important medication groups so that you can update one and then it'll be updated everywhere, which will help a lot with things like this. Feedback. So one of our great informatics managers set up a 2-minute feedback form that we were able to send like a little QR code to try and get feedback from everyone, including the frontline people. And then we were able to set up meetings to sort of discuss this feedback. I thought this was very helpful. So there was a lot of really important stuff that came up. So there's some confusing order presentation. There were a lot of workflow friction points, and that helped us really figure out what needed to be acted on when. But there also was just like change is hard. So we received a lot of reports of like issues, and I think that the feedback form was really helpful because based on the feedback, I was thinking that everything is a must everywhere. But it turned out the majority of people actually liked it. So being able to get that input from maybe some people who are not always the loudest voices, and the people, you know, it's easy. It's common to report a problem, but to not report when things are going well, right? And so to try and get more of a sense of what's going on as a whole. And so this was very, very helpful, and it helped us balance too, like what are those changes that need to be made because it's a larger issue versus what are small things that we can adapt to with personalization. And then in terms of monitoring go live, so like a lot of places, we have like a safety event reporting system. So after that, I think Sean and she may have already gotten this, but I get a little ping every time there's anything involving insulin now in the safety event reporting system, which is great. It really helps us, you know, stay on top of reports. And so sometimes we get an email and get a safety event. Sometimes we just get a safety event. But I thought what was really interesting was that because we changed part of how we're managing diabetes and insulin, people have sort of like an increased heightened awareness of that care. So now we're actually getting a lot more safety events just about insulin and diabetes in general, which is bringing forward a lot more opportunities to improve care, which Sean is all over. We also continue to do check-ins, so trying to check in with providers and nurses. And then we are continuing that feedback. So we did a second survey and we're going to do a third survey to sort of get the longer term, like now that you're getting used to it, what else do we need to change and update? And so we're really trying to continue all those loops. So some of the big takeaways. So one has to do with stakeholders. So trying to make sure you get everybody involved, which is hard. So give yourself a little grace when you need to invite more people. I'm a person who likes things to be perfect from the start. So iterative design is something I always struggle with, but it's important to do. This is something I've learned like 50 times in my career, but continue to learn it, is don't assume workflows. You don't know other people's workflows. So go in and ask them, follow them, find out exactly what they're doing. Kind of along the same lines, it's important to ask people how they want to learn. Everyone has different strategies of how they learn, and also different tools and different interventions require different learning and education. Timing matters. And I think this is a really hard one right now, because especially in informatics and technology, there are so many changes coming so fast. Like I can't even, like, literally our EMR vendor is coming out with like 10 to 20 new AI tools every quarter. And so how do you balance this, like, change is important and there's a lot of improvements versus like we are going to lose our mind and don't know what's happening. So it's a hard thing to balance, especially in a time like this. And so it's a balancing act. And then also making sure you have good feedback, areas for feedback, so that you can actually keep those loops open and try to get broader feedback from everyone, even some people who may be a little bit of the quieter voices. And sorry, I spoke very fast. I just want to thank everyone. So this was a really big project, and I didn't put any names up here because I was afraid I was going to forget people. And even with that, I still forgot one of the nursing groups. So nursing informatics helped. Our nursing leaders, our frontline, our professional development and innovation, the diabetes educators played a huge role. Our pharmacy and pharmacy informatics were huge. They did a lot of building. Our CI management helped with a lot of the follow-up. And then our EPIC training team really sort of went above and beyond, trying to work out all of our issues with our play environment, and they're still working on it. So this was like definitely not a small group. Sean and I were just a little part of it. But that's it. Thank you.
Thanks to both of you for presenting this insulin management program, I'm going to call it. What I think is really remarkable is that you embedded all the challenges you had along the way from the very beginning. And I think most people are like, I don't want to talk about that. It doesn't shed us in a really great light. But if there was ever a case for implementation science, you just stood there and made it. So I'd open up the floor to any questions. Okay, what would you do different?
Well, Sean needs to respond too. I think getting more, I think we made a lot of assumptions in the beginning. So I think going to the front line, getting everybody's opinions on who all needs to be involved and how from the beginning would have been really helpful.
Yeah, I was gonna say the same thing. I mean, I think some of the nuances of how it would change, like the actual insulin administration, like we didn't know because we didn't know what we didn't know. And yeah, and I think maybe trying to engage some others that may have implemented the insulin calculator within the last 5 years to know some of those. I mean, the nuance of the DK no A thing was honestly like a lot of it. And the patient's own insulin pens. There was a lot of different existing implementation challenges we were trying to do in that. But to be honest, I think sometimes doing something is better than nothing. And like there was a desire on my part to like plan before we went live. But like, it's just what it is, right? You know that you're going to go live and there's going to be issues and you're just going to deal with them as you go. And I didn't mention, but we also went to an endocrine consult only service, like as this happened. So there was a lot. But it was needed because of that too. So you just deal with things as they come up and you just know it's going to happen. So
it's another one of those multiple changes. So as the PEDS residency program is changing, like we're having fewer subspecialty services, which means we now have like more and different providers placing these insulin orders, which creates its own challenges, but I think also helps somewhat from a provider perspective to have this order.
Other questions or comments?
I just want to say thanks for sticking with it, with all those challenges.
What about an update? How's it going?
So we actually, so I don't know if I can give her an update, but so we are going to send out another feedback survey to get feedback on that. Most of our issues that we're having right now have to do with provider ordering. And so I think we're getting better on that. There's one other little issue with like 2 boxes showing up that we're talking to Epic with, but only 1 dose is actually showing up and that's the recommended dose. So there's a lot of things that we're still tweaking.
that we're working on. And we're going to go. So speaking of things that this brought up, so this has brought up other issues with like our hypoglycemia management and our insulin order. So we're actually updating all of our order sets that contain insulin. I was just talking to Sean about that. And then we're going to remove insulin orders from our general list. So people will have to order it through the order sets with some of that embedded clinical decision support. So it's a lot of change.
Yeah, and I get all the safety events related to insulin, and I'm very thankful because it's made Elizabeth a very close friend of mine that I ask about all the things about clinical decision support. But it's, you know, quality improvement, right? You want to like bake in as much to be automatic as possible. And what it's enabled me to do, or us to do, is to like, this tool allows you to bake in a lot more that creates safety. Like, for example, there was one safety event where like a nurse, like there was an inappropriate insulin calculated for the carbs. And now I changed it to like do a max amount of carbs for that patient. Like you can do it by the patient age. And that it'll like default out when you enter that, as opposed to before that wasn't an option. So it's allowed for a lot more safety checks in the system. So I think ultimately 10 years down the road, it's like been more safety things, but I'm thankful because I think we're going to solve more. Yeah.
Having been a provider who places insulin orders, godsend. Yeah. So, I mean, you used to have to sit down and have uninterrupted concentration time because super easy to make an error previously prior to using this. So you're tracking then the number of errors. Is that your outcome?
So kind of, yes, we are. I think also we're sort of tracking some of our feedback. And then I think I eventually I'd love to track our actual it's like all of our insulin errors in general. So because right now the calculator errors are kind of getting mixed in with all the insulin issues. So I think we'd love to follow safety events. It is going to be interesting though, because we definitely saw a spike with this being introduced. And some of it is related to the calculator, some of it isn't. So it's going to be interesting, like how long it's going to take us to get back to that baseline that we were before and to actually get lower.
Great. Questions about anything else? All right, I have a question for you, Allie.
Yeah.
Because you're involved still. You don't have to keep standing there. And I'm going to hand you this. We heard about multiple different CCGs today and how people went about and did it. And in the world of research, which is different, there's been a significant movement to including families in protocol development. So can you please comment on including families in CCG development?
Yeah, it's something that, to my knowledge, we have not done as far as algorithm development goes. However, as I mentioned earlier in the day, we have included families in development of the patient and family education. I don't think that means that that's something we would never do. It's just not something that anybody has championed to date. We recently, the patient family experience team just came back under CQS. So I think that makes that piece of all of it a lot easier. Something that we used to do, and we do less now, although I think it's something that we should probably get back to, is looking at our PFE comments as a part of the current state.
So
analysis.
PFEs are patient family experience.
Yes, patient family experience. So scores and comments. So that is a part of our standard, our internal standard work for our consultants to request that from our PFE team. I can't confirm how frequently it happens, but that is something that I'd say happens more often than actually having them like in the room for the algorithm development piece. Yeah.
Go ahead.
Yeah, I just was gonna, I'm so glad you said that, because actually right after this, I'm going to a CCG meeting because we're developing like an outpatient, we're developing an outpatient CCG for like obesity referrals. And I actually think that probably is an appropriate place for there to be a patient family voice in an algorithm development. So anyways, I'm glad you said that.
Any other questions or comments about the day go?
Great content.
Yeah. Thank you. All right, so then in wrap up, I want to thank all of our participants and all of our speakers for your kind attention, as well as interest in making evidence-based guidelines usable at point of care for the patients that we serve. Today, we heard about the CCG program, how it's organized, how CCGs are generated, how outcomes are monitored. We also heard about the asthma CCG and how it was generated, and the new addition of the modified PAS that we'll hear more in the future about what that looks like. We also saw that the CCG resulted in a decreased length of stay from 2.6 to 1.1 days. So that's tremendous work. The autism CCG was presented and highlighted really the challenges with boarding that really resulted in this being born, and the application to patients that are very difficult to identify sometimes and spot because of the spectrum of diseases. And you all were very clearly interested in this particular CCG, and I'm confident that Dr. Wanta will take you guys up on, and anybody up on the contributions that you hope to be able to add. Finally, the insulin management guideline and implementation. Really, I was delighted that you focused on all of the challenges that you guys had with this implementation, because it really makes a difference in how you move forward to address the issues. You also talked about how really the CCG has tentacles, right? So it began identifying all these other areas in the hospital that have insulin delivery and all the things that need to change as a result of that. In looking to the future, we see opportunities for more CCGs, as well as working towards establishing baseline metrics so that we can very clearly identify what our outcomes are, and if we've met those outcomes that we set forth. And in the meanwhile, we know we are striving to use the evidence to improve care at the point of care for the children and families that we serve here. And we know that those children and families will continue to benefit from the application of research when they come here for care. So with that, I thank you all for your participation, and we'll bring the meeting to a close.